Honorable Minister of Health, Honorable Minister of State for Health, Honorable Permanent Secretary, Honorable Members of the High Table, Honorable Commissioners, WHO Country Representative, partners, distinguished guests, ladies and gentlemen. It's an enormous pleasure and a great honor for me to be here with you at this very important event, the Presidential Summit on Universal Health Coverage and the technical workshop today and tomorrow. Thank you very much for this invitation. This is highly appreciated, and I very much look forward indeed to the following days and to the discussions. I will give a presentation on with the following title: Achieving Universal Health Coverage, Analyzing Relevant Options. I'm working in the Department of Health Systems Governance and Financing, and my name is Inka Mathauer. I was just told a couple of times already that my name somehow sounds Nigerian. I don't know why. It's also a very German name, but it's a nice feedback that I got for those past 2 days. So let me start. I will outline some core challenges with respect to universal health coverage, and then actually go into the details, its definition, implications, and dimensions. I will then talk a bit more about health systems financing specifically, namely the health financing functions and objectives, and then spend a large part of the second part of my presentation on how to cover the informal sector and the poor, because I think when we talk about expanding universal health coverage, that is really one of the core questions. And I finish with some key and summary messages at the end. Let me start with this graph, which I think very greatly actually illustrates the problem. Here you see about 50 countries that are bad from the left to the right. On the left-hand side you have poorer countries, on the right-hand side you have richer countries. And the yellow dots actually shows the average in each of these countries that are just mapped along their level of income with respect to the percentage of births attended by skilled health workers. Now what we see across the countries is quite worrisome. There is an enormous inequity across countries. But equally worrying, and maybe even more worrying, is the inequity that you see within each country. And that's the bar that you see going from the bottom to the top. The top end of the bar actually shows the average of the highest quintile in that country, whereas the lowest end of the bar shows the average percentage of the lowest income quintile. So this enormous inequity is quite worrisome, apart from the fact that we see that millions miss out actually needed health services. The percent here attended births by skilled health workers. Oops, what happened here? So, another reflection of this inequity is, just giving you some numbers. When people use health services, in fact, what we find is that globally around 150 million people suffer severe financial hardship each year. So basically they're spending an enormous share of their household income just getting health services.
Sorry to interrupt. Please, a copy of our presentation is in the back. If you check your bag, you will see a copy of our presentation, so that you don't have to strain your eyes. Okay, thank you. Sorry to interrupt.
No problem.
That minute is not part of your time.
Yes. And in fact, yes, please take out the presentation, because I wanted to make one specific note later on, so it would be good if you have it, and also not to squeeze your eyes. Okay, coming back to the second point, what's also found is that 100 million are pushed below the poverty line because people seek care, because they must pay out of pocket at the time they receive them. Now, what are the causes? What are the causes of this challenge? There are a number of causes, a number of factors. First of all, there is exclusion linked to factors outside the health system. There are inequalities in income and education, in access to water sanitation. There's social exclusion associated with factors such as gender, migrant status, ethnic affiliation, etc., etc. So there are a number of factors explaining exclusion. And another word often used for this is the social health determinants. Now, another important factor or set of factors is around the health system, namely weak health systems. What we find in many countries is that there are insufficient health workers, both in terms of numbers, but also in terms of skills. There's lack in medicines and health technologies. What we find is that service delivery is ineffective, information systems are poor, and there may also be weak government leadership. We will have a number of presentations today and tomorrow that will specifically also relate to some of these health system building blocks, as they are called. And the third factor relates to health financing systems that in many countries do not function. And in fact, for each country, whether rich or poor, the health financing system is a continuous challenge to address and to work on. And so the other parts of the health system that I just referred to, they cannot function, they cannot work if the financing system is weak. And so that is really one important reason why health financing is so important for moving towards universal health coverage. Now, what is universal health coverage? Let me actually get into a definition. For the first time at a World Health Assembly, in 2005, a resolution was passed that was specifically on universal coverage. It urged countries to develop their health financing system to ensure that all people have access to needed services without the risk of financial hardship linked to paying for care when one seeks services. And very specifically, this resolution defined universal coverage as access to key promotive, preventive, curative, rehabilitative health services of good quality, and that's very important, of good quality for all at an affordable cost. Just as an observation, I think when you talk about universal health coverage, we often focus on curative care. But I think it's very important to make clear that when we talk about universal health coverage and trying to find ways of how to actually finance that and how to provide that, we do also have to focus on promotive and preventive care. The 2005 resolution was actually followed by another resolution in 2011 from the World Health Assembly. And again, it's very much within the same line. It asked member states to develop their health financing system towards universal coverage. And it also asked WHO, the Secretariat, to develop an action plan to support countries in doing so. And in fact, we're getting lots of requests now for countries to work on that. So the core questions related to universal health coverage can really be summarized with this slide. Now, how to alter the health system in a way that first, the gaps between the need for and the use of services are reduced across the population, not just for the better off, but across the population, specifically for the poor and vulnerable groups. And also, how to alter the system so that the quality of health services is improved. And last but not least, very importantly, how to alter the system so that financial protection is improved for the population as a whole. The idea of universal health coverage, even though it just came in a resolution in 2005, is not new. In fact, it has been there since long, the idea and the aspiration along those lines. It is there in the WHO's Constitution of 1948. The idea was also there clearly in the Alma-Ata Declaration of 1978. And then later, recently, it was already taken up in the World Health Report of 2008 on primary health care, which was titled Now More Than Ever. And very recently, really then in 2010 with the World Health Report titled Health Systems Financing the Path to Universal Health Coverage. And I think it's also this report that really contributed to the discussion and also created a momentum both at global level but also at country level to really push this idea of universal health coverage. I just also want to mention, of course, there are many other major events, so I would like to mention the Abuja Declaration, where heads of states actually committed themselves to spend 15% of the government budget on health. There was the Tunis Declaration in 2012, where Ministers of Finance and Minister of Health committed themselves to address this universal health coverage challenge. And yeah, as I said, there is a global momentum, and there is also a momentum at country level across this region here, which is very encouraging. Let me talk a bit about the implications of universal health coverage now, specifically with respect to health financing and this issue of financial risk protection. In fact, universal health coverage implies financial risk protection. That means that the cost of care does not put people at risk of financial catastrophe. In simple words, it basically means that we do not want that people spend, more than 40% of their disposable household income. That means once food and other essential expenditure has been undertaken on healthcare. There are other thresholds. We're using at WHO, we're using the 40% threshold, but of course one can choose lower thresholds as well. But the key message is households should not spend all their money or a large part of their money on services out of pocket. And so in that sense, there's also an implication for equity of access according to need. So access to care should not actually be dependent on how large is my pocket and how much I can spend. So it should be dependent according to the needs that I have. Likewise, universal health coverage is associated with equity in financing, which really means simply that contributions should be made according to the ability to pay. Thus, people with very low income or with no income, obviously they cannot contribute to the overall health financing system of a country. Health expenditure, which would also include health insurance. Private health insurance obviously also is one form of pooling. But of course it has certain implications that I come to talk about. But really the idea is that the pooled funds are being expanded. And as they're being expanded, countries have the means to expand on the three dimensions. Now, obviously, for countries with resource shortage, it might be very difficult to expand this yellow box in the three directions at the same time. So countries might have to in practice actually have to take a choice. Some countries, for example, South Korea has said, okay, let's first extend to the non-covered. So within a very short time, they were actually able to cover, 100% of the population. But still, even today, they are challenged with the question of how to reduce their overall out-of-pocket expenditure. Other countries, on the other hand, would have said, okay, well, let's take what we have at the moment with the covered population and let's first try to expand the benefit package for them as well as reduce the out-of-pocket expenditure. So there are clear policy choices here. Yes, and then let me just mention, in a way, there is a fourth dimension which is not presented here. When we talk about services, I earlier mentioned already that service delivery is a very important aspect of universal health coverage. So when we talk about services, obviously what we're talking about is that services are available and that they are at good quality. So that's a very important aspect related there too. Very briefly here on coverage targets. Obviously when it comes to population coverage, what we want eventually is 100% population coverage. However, when it comes to the services question, so which services should be covered, the question is more tricky. No country can actually provide all services that are out there, all kinds of technologies. As a starting point, of course, for low and middle income countries, what we want is that there's a good package of essential services. But then when it comes to actually expanding it, there are a number of questions. What can the country afford? what are the health services priorities in that specific countries, and what are societal preferences for specific services. Also, one can apply specific criteria such as cost effectiveness. So, let's say, in order to get value for money, a country decides or may want to decide, well, let's focus first including cost-effective services. But anyway, this is very much a policy process at country level. When it comes to the last question of how much of the cost should be covered, again, the question is not that, the answer is not so straightforward. It's not necessarily 100%. For some services, it might make sense that there is some cost sharing. For other preventive promotive services or for specific population groups such as pregnant mothers or children, one may also say no cost sharing. So in principle, yes, the aim is to have a very high level of prepayment, so to have a relatively low share of out-of-pocket expenditure as of total health expenditure, but not necessarily 100%. Why? Because there is something called moral hazard. So if people have coverage for everything, obviously there might be irrational consumption of services. So now let me talk a bit more about health systems financing. It's only one aspect of universal health coverage, but it is one important pillar. And if we don't have the the health financing right, then obviously it will also be very difficult to improve on the service delivery side. Now, here you can see the three core health financing functions. Initially, again, when one thinks of health financing, one would intuitively, first of all, think of resource collection, which you see here on the on the left-hand side. But equally important are the other two functions, which is pooling, so really the accumulation, the bringing together of available funds, so that we have prepayment. If there's no pooling, we don't have prepayment. And on the right-hand side, we have the health financing function of purchasing, which really is the buying of services. So I'm just reading out the questions related to the three health financing functions. Who pays, which population groups pay, who collects which institution, and what are the mechanisms of collection. With respect to pooling, how to share risks, how to arrange for cross-subsidization between different pools, if there are, or between different population groups. And with respect to purchasing, what to buy, which services to buy, from which types of providers, at what level, and also how to pay providers. At the top you see the overarching function of stewardship, which obviously guides and directs each of these health financing functions. The important point I want to make here is that there is need to think in terms of health financing along those functions. So have a functional approach rather than thinking along schemes. So have a scheme for the formal sector, have a scheme for the informal sector, have another scheme for specific vulnerable groups. Yes, that is the case in countries, but nonetheless for the analysis, and that's what my presentation also intends to do, is for the analysis, let's think along the functions across the different schemes. So coming back again to the choices, to the policy choices that need to be made. I referred already to what we call our universal health coverage box. So choices need to be along three dimensions. But at the same time, choices also need to be made on the health system side and on the health financing system side. So on the three health financing functions, the revenue collection, the pooling, the purchasing, but also the service provision. And that's where we come back again to the very important aspect of universal health coverage, which is the service delivery. So reforms will be needed to improve how the health financing system performs and also how the service delivery performs. Now, there are various health financing mechanisms for universal health coverage, and they comprise all health financing mechanisms with prepayment, with pooling, and those that ensure equity in access and also, ideally equity in financing. They are clustered around tax-based financing, health insurance or social health insurance specifically, and in practice what we find is actually mixes of both. Let me just say a little bit about tax-based financing. What I often notice in discussions around universal health coverage and financial risk protection is that the tax-based financing, which is really the government budget on health, is often sort of aside, it's not really at the core of this discussion, even though in fact the largest pool in a country is normally the government health budget. So that is one very important risk protection mechanism. Now we do know, of course, that when it comes to the level of service delivery, when it comes to seeking care, it still might, you know, I outlined those figures. People will still encounter that services are not free at the point of use. But nonetheless, tax-based financing is one important risk protection mechanism. So it needs to be, you know, brought to the forefront again. Now, let me also just briefly mention that these health financing mechanisms, they are often combined with other health financing approaches, let me call it like that, such as results-based financing or performance-based financing, or, you know, the different terms. Now, this in fact is a mechanism of purchasing. It's, you know, making purchasing more strategic, but it's not as such a health financing mechanism. It can also be combined with vouchers, etc. And again, just coming back to the point, what we do find in many countries is we have a mix. We have hybrid financing based on tax-based financing and social health insurance contributions. Let me also say a little bit about, I allowed myself to put that in quotation marks, traditional social health insurance. Now, it can mobilize more resources if general government health expenditure is maintained. That's very important. So the idea is that ideally you free up resources for the poor or for those that cannot join social health insurance. It also gives entitlement to a benefit package, and obviously also improves financial risk protection for those that are insured, not necessarily for those outside. And also usually it's relatively progressive because it's based on salaries. But, there's a big but, if social health insurance is only contributory based, it only covers normally the formal sector employees. And so it can also easily lead to a segmented health system. And so if we go back to other countries that have introduced social health insurance, let's say a couple of decades ago, you will actually see this segmentation to be even stronger. Very much so in Latin America, for example. So here comes one very important message that I want to make. Now, subsidization through general government revenue is required for vulnerable groups or for those outside formal sector employment to get coverage if the social health insurance scheme or if the national health insurance scheme is supposed to be there for the whole population. So that's why I put it in quotation mark traditional, because in fact in many countries we do see this. There's increasingly more subsidization through general government revenue, and again, as I was saying, you know, what we find in countries is a hybrid financing. It's, you know, it's a combination of the two. So let me come to the most important. Well, I think from a health financing perspective, one of the most important questions: how to cover the informal sector. Now, in fact, in order to approach this question, let's look at the starting point. There are two necessary and sufficient conditions for health financing for universal health coverage. One is compulsion, so mandatory payment. Why compulsion? Because though some, not all, some who can afford might be unwilling to buy health insurance or to pay. Now, with respect to taxes, they're mandatory, of course. There is, so to say, less of a, well, I shouldn't say less of a problem, but let's put it this way: compulsion with respect to social health insurance might be more difficult to enforce. So compulsion is one of the necessary and sufficient conditions. The other one is subsidization, as I referred to already. Why? Because some people will be too poor or they will be too sick to be able to buy, to afford voluntary health insurance coverage. One condition without the other won't work. If there are only subsidies for those that cannot pay, it will not be sufficient because the rich or the healthy, some of them might tend not to join. They may simply try to buy separate packages. And compulsion without subsidies imposes a too heavy burden on the poor and the sick. Now, so this is the concept. Obviously, putting that in practice is very challenging. Namely, enforcing these conditions, especially the compulsion, requires a very strong role for the state in health financing. And this is even more difficult in a context of high informality, because it poses critical challenges to realize these conditions. Now, in a country with a very large informal sector, it's harder to do private health insurance or voluntary health insurance because there's adverse selection. If I know that I will need it because I have a history of being sick, obviously I would be more inclined to buy it. If I'm young and healthy, then obviously I would maybe say I don't need that. Now, also for a country or for a system with a large informal sector, it's difficult. It's difficult to distinguish differences in capacity to pay. You will have there are the poor, but then there are also non-poor people in the informal sector. So how do you distinguish between them when it comes to deciding who gets subsidized or not? Now, obviously, this is not so much a problem if a system can ensure service guarantees and financial protection on a non-contributory basis. So the most prominent example would be the UK, but we could also argue that in Sri Lanka, some of these conditions are there. So what are the options to finance universal health coverage for the informal sector? Namely, with an explicit entitlement. And it's, well, I'm presenting here 4 options. Obviously, within the country, they're not mutually exclusive. You would actually find several of these being in place in the country. So the first one is if you have no subsidization at all. The non-poor, the formal sector would then have to pay and buy a full premium, or otherwise they would have no entitlement. Now, as I say, this is trying to sort of categorize and typologize, so you would always find in a country maybe a slightly different situation, but sort of the typical example here would be community-based health insurance in many of the West African countries. It's basically voluntary, and until recently it was largely unsubsidized. But even in the US, before Obamacare, would fall under this. If you're in the formal sector, then you would have some insurance via your employer, but outside formal sector employment, people would have to buy voluntary health insurance. Otherwise, and pay a full premium, otherwise they would have no entitlement. The other extreme, if I may say so, of this range of options is to finance coverage for all those outside the formal sector via general tax revenues with automatic entitlement. So if I'm not in the formal sector, I don't have social health insurance, I would be automatically covered by the government through general tax revenues. And the most prominent examples are Thailand with the universal coverage scheme, or Mexico with its Seguro Popular. Sort of in between is the third option. It's guaranteeing and financing from government budgets, or here number 3, certain health services for all, and there would be contributions for a more comprehensive package. We do find this now in many countries, again here in the region, in the sub-region, what's called free care services, or in the Francophone countries, gratuité, especially for maternal and childcare services. And the last option is a combination of direct contributions plus government subsidization to expand coverage. And then obviously the idea would be to have full subsidization of the poor. I think in terms of the concept, but also what we see working in countries, is that the poor are being subsidized. Now, there are a number of examples here in the region. Gabon is pursuing such an approach, Ghana, Rwanda, but also from Asia we have examples of China and Vietnam. So now let me go in more detail of each of these options, but again, keeping in mind that countries might apply several of these options. So the unsubsidized contributions by the non-poor informal sector, or let's say the community-based health insurance, what does that imply? Well, usually they're voluntary with respect to the community-based health insurance schemes. They're normally often small scale, they're close to people, which is good, and they help establish the insurance idea, the insurance concept. But, again, there's a but. They're small, they're often fragmented pools, very small fragmented pools. There's no cross-subsidization across those small pools. Often, not always, payments are flat, and thus they're regressive, and they're very high administrative costs, which often do not really enter the scheme as such because it's being supported by donor organizations. But clearly there's adverse selection, and what the evidence also shows is that the poor cannot afford these contributions, and thus they're often excluded, very often excluded from such schemes. what we also know, and again that's really a key message that I want to deliver here, is with this community-based health insurance schemes, what we find is very low population coverage rates. And thus very limited financial risk protection, because often the benefit package is relatively small. So no country has achieved significant population coverage through voluntary contributions from the informal sector, and the US is the example where before Obamacare about 40 million of the population had no access to care. So no country can actually, I think that's the evidence that's really coming out, can effectively progress towards UHC through this approach. Let's come to talk about the other side of the pole of the range of options, which is what I would call universalist approach. It's fully funded coverage from government budget. As I said, we have these two examples that work, these two known examples that work from Thailand, from Mexico. In fact, interestingly, both countries began with the intent to have a co-contribution, to have some contribution from the covered population. But in fact, they then eventually gave up as they realized it's not worth the cost of collection. What are the advantages? Well, it's administratively simple. There's no targeting, because if you're outside the formal sector, you would automatically be entitled. So there are no additional revenue collection costs, because it comes from general tax. And also there is no additional bureaucracy for this purpose. Of course, there are challenges and there are potential disadvantages. The physical constraints.
Sorry, Inka, 2 more minutes.
2 more minutes?
Yeah.
Okay, so I have less than 30 minutes. Okay, I'll be very, but let me make that point very clear. Unless there's strong political commitment, physical constraints will limit this approach. And now here, please take the presentation in front of you, the paper printout, and please correct, because there was a typing mistake that happened last night when we transferred this into this format. Cross-country evidence shows that around 3% of general government health expenditure of GDP. Here it's correct on this presentation, but it's wrong in your printout. It's not total health expenditure. That wouldn't make much sense. It's 3% of GDP. So please, just correct this and really, put it in your presentation. And obviously, there might also be a risk of fragmentation if separate schemes for the non-contributors are in place. Free care services. Now I have to see how I cut down on this. Yes, that's a public commitment to provide at least some services for some groups. It's easier to implement than a contributory-based approach. But there are also challenges. Often the increased utilization rates resulting from the free care are often not in line with the supply side. And that's specifically the case when the free care services are not funded, they don't have an explicit budget line. And so people would still experience when they seek services that they're not free at the point of use. Now the challenge really here is to move from specific free care services to a larger package, to really expand the range of services. And that's the challenge, or would it then remain a two-tiered system? I mean, this is just what's happening right now in countries, so there is maybe not yet an example of a country that really has moved from its specifically defined free care services to a larger package, but to be seen. And then we have this combination of subsidization and contributions. I also often like to call this partial subsidization. And the higher the share of subsidization, the more attractive and the more inclined people are actually willing to sign up. It's clear that no country gets to universal population coverage without some budget transfers, because, as I was saying, some people are always unable to pay or unwilling to contribute. And we do find this again even here in this region. Ghana's National Health Service actually, its revenues are about 60% about coming from tax financing. Rwanda, the same. I don't have the precise figure though. Let me say a little bit now on Rwanda and Ghana, because I think it's often brought up in the discussion with respect to community-based health insurance as an example that it would work. Now, it's true, they did have community-based health insurance systems in the past, But Rwanda in 2006 and Ghana in 2005 actually decided to scale it up, and they transitioned their system to a new national health system, and they now have very high level of subsidization for the poor. Also, China is an interesting example. Rwanda and China both have enormously high population coverage rates, about 90% for the, so a large part of the informal sector is covered. But it's mandatory, so that's the difference to the traditional community-based health insurance scheme where it's voluntary. So in Rwanda it is mandatory, in China in practice, even though on paper, as per the law it's not, but it's in practice mandatory. Because local governments are heavily involved to enroll people, they have incentives, they push for that, and let's put it this way, they're very strong governments both in Rwanda and China to implement these policies. So I think it's important to set that in the right frame, that community-based health insurance, even though the term is still being used, like in Rwanda, it's still called a mutual scheme, the meaning, the substance has changed. And I'm very happy with continuing using these labels, but I think they have to be clear of what's behind. And so Rwanda and Ghana, they're no longer community-based health insurance schemes in the traditional sense. May I finish with two final slides, key summary messages. I'll be very short. Now, just to come back again, what means universal health coverage? It has basically two core aspects. It has a health financing aspect, which relates to the fact of ensuring financial risk protection, and it has a service delivery aspect, which is about providing or ensuring that good quality services are available. What's important for countries, and just like here in Nigeria, is to build upon the existing. And here there's a lot to build upon. But for many countries in the region and in other regions as well, I think the challenge is really about to reduce fragmentation, to increase pooling. There's no blueprint to do that. Each country has to come to its own architecture, but we do know some things. And in most of the low and middle income countries, if not to say in all, there's need for increased government spending on health, so commitment and need to move towards the Abuja Declaration target, and that can also be done via what I would like to call new revenue raising mechanisms. Often it's referred to as innovative financing. And my final slide, again, just really making that message again, repeating, there's a need to subsidize the poor and specific informal sector groups. There's need to make payments compulsory for those able to pay. And last not least, in a context of high fragmentation, which we do find in many, many countries here of the region, there's need to align these different health financing. I think to have a health financing strategy or a universal health coverage strategy, be that a separate document or be that a chapter in the National Health Sector Plan, that's really important and very helpful to outline that overall vision of what should the health system architecture and the health financing architecture look like. This is the case here in Nigeria. There is a health financing chapter in the strategy, and I think also this event certainly will contribute to further develop and update it. I mean, the plan is until 2015, so I think this comes at the right time to make these reflections here. Thank you very much for your attention, and I'm happy to